All right, well, I'm going to go ahead and get started. We're very excited to have Dr. Daniel Hinds with us today to talk to us about a very, very important topic, um, pulmonary issues with FSHD and respiratory. Dr. Hinds is a clinical assistant professor of Pediatrics, Division of Pulmonary Medicine at the University of Iowa. Dr. Hinds is the fellowship director and director of a rare and diffuse lung disease program. He also has interest in, I'm going to mess this up, bronchopulmonary dysplasia. Did I say that right?
That was good. Yeah, that's great.
Neuromuscular disease and pulmonary hypertension and asthma. So thank you so much, Dr. Hinds, for spending the evening with us on this important topic. I'll let you go ahead and share your slides and we can jump right in.
Sounds great. Give me just a second. Okay. Can everybody see those okay?
Yeah, we can see it.
Awesome. Well, thank you again for the invitation. This is a great opportunity for me and to kind of get some feedback on what things are important to you and hopefully learn about what things are important to me when I'm taking care of patients with FSHD and looking at their lung disease. So a couple of objectives. Hopefully you'll leave here with a basic overview of and an understanding of lung function and lung disease in FSHD as I think about it. Overview of how we test for lung disease in FSHD and then how we treat it depending on what we find. I don't have any disclosures, so I always like to start talks with an intro case. So let's say we have a 15-year-old who has childhood onset or early onset FSHD who comes into clinic for evaluation of their lungs. This patient, thankfully, does not have significant respiratory issues or coughing on a regular basis. They don't have emergency department visits or hospitalizations with illnesses, but they do snore consistently. They do wake up fatigued. And there is some coughing, choking, and gagging with eating and drinking, more liquids than solids, which we would call dysphagia or potentially dysphagia. So I think this is a pretty classic case of what someone might come in with to see me in the clinic. And so we'll come back to that after we talk about a few other things. So just so we're all speaking the same language and on the same page, the purpose of breathing, there's two phases of it. One is to get oxygen into your body as fuel for your cells, so oxygenation. And the second part of it is ventilation, or breathing out the waste products from that energy consumption and breathing out carbon dioxide. So get oxygen in, get carbon dioxide out. In relation to FSHD, I think there's a spectrum of lung issues depending on how much neuromuscular weakness there is for each individual patient. But classic things and the high points of things that we see, one would be difficulty with airway clearance. So having weak muscles can lead to weak coughing and difficulty getting mucus out of your lungs. There's a lot of, especially with the kind of oral motor and facial weakness issues, there can be a lot of swallowing issues. So weak muscles leading to difficulty with swallowing of liquids and secretions. They can go down your trachea instead of your esophagus, so going down the wrong pipe, leading to an increased risk of pneumonia and lung inflammation. There can be sleep issues, so weak muscles leading to shallower breathing at night and increasing the potential for elevated CO2 or hypoventilation and or decreased oxygen or hypoxemia. And this is especially pronounced when you see snoring. And then in the most severe cases, when patients maybe lose the ability to walk or have enough weakness that they are having a hard time moving their chest wall, there can be hypoxemia or low oxygen levels or hypercarbia even during the day in the most severe cases. So how do we measure and how do we track lung issues in clinic? I think the two things we look at are, one is clinical history. So what is subjectively, how do you feel like you're doing, or how do you feel like your children are doing? And the other is we try to get some objective measure with pulmonary function testing. So for clinical history, the important aspects that I like to ask about and focus on, do you have coughing? Do you have coughing every day? Do you have a hard time getting that cough to go away? That kind of stuff is really important to me. Snoring or gasping with sleep that could indicate the need to get a sleep study, if that's appropriate, is really important. Coughing, choking, gagging with either your drinking or dysphagia. So when do we need to get a swallow study, can be really important. And then just functionally, when you get sick or when you have breathing issues, are you needing to seek healthcare services? Do you have to go to the emergency department? Do you have to be hospitalized? Do you have recurrent pneumonia? Are you frequently needing antibiotics? Are all really important in identifying patients that we may be able to provide things for to help with these issues. And then pulmonary function testing is the other way of evaluating your lungs. So spirometry, or doing a big breath in and a forced hard breath out, looking at how well you get air in and out of your lungs, is really important. If you have a hard time getting air in, that can look like restriction or restrictive lung disease. And that's one of the main things that we're screening for with spirometry. But we also can be looking for obstruction or having a hard time getting air out. Normally, when we look at obstruction, that would be a sign of asthma. But that's not always the case. And even in neuromuscular diseases, there can be some signs of obstruction that maybe it's just because of the particular muscle weakness that you have and not because of any other inherent lung disease. So that takes a little more nuance of trying to figure that out. And thankfully, there has been a little bit of research. There was a nice paper in 2016 that showed there is kind of a particular pattern with spirometry that in FSHD patients that tends to make the loops look a little more box-shaped. And I'll try to show a kind of an example of that and what that looks like. So then the other thing that we look at are oxygen levels when you check into clinic, so getting vital signs and just making sure your oxygen levels are normal. And then oftentimes we'll get a capillary blood gas as well, especially for patients who have a hard time walking, to make sure that their CO2 level is normal. So this would be an example of a patient with who's spirometry in a patient with FSHD. So I always start when I'm describing this to families with looking at the loops on the right. So the red and blue lines are before or the two attempts, and they're very consistent. So I think this is what this patient's lung function looks like. The loops on top are them breathing out. The loops on bottom are them breathing back in. When you first breathe out, you empty out your trachea, and so you get most of your flow out early. And then as your lungs branch, each airway gets smaller, and so the flow should slowly decrease, with the ideal line or the projected line being the gray one up here. So this patient, I would look at these loops and say it's a little box shape, especially for the breathing out. The breathing in loops look more normal, and they just look a little bit small. They look a little bit restricted. And then we look over at how your values compare to other people of the same biologic sex of the same height. And that's what tells us whether there are any abnormalities in this lung function. And so we used to look at reference percentages. Now we look at Z-scores, which is just a way of doing stats on a bigger population. And all of these values look a little bit low. So I would look at these and say, well, I am concerned about restriction, but I also might be a little concerned about obstruction. So just making sure there's not a chronic coughing history or a history of asthma that we could be treating better. But knowing that this patient has FSHD, I do think that the box kind of shape to it is pretty normal for that disease process. And so that keeps me from going down a different road of looking for airway anomalies or maybe a CT scan or something else that in a patient who doesn't have FSHD, I might think about. And then the other thing that we look at is respiratory muscle strength testing. And so what is that? That's doing a MIP, a MEP, and a peak cough. MIP is max inspiratory pressure, or how much force can you generate on breathing in. A MEP is max expiratory pressure, how much force can you generate breathing out. And a peak cough is how much force or flow you generate when coughing. And so basically, the only reason that we're doing these tests is to see, do you qualify for any piece of home equipment that could help you with your breathing if your symptoms would indicate that you also might benefit from this. So if your FVC, or your forced vital capacity on the previous slide, the total amount that you can breathe out, If that's less than 50%, then that qualifies you for both a home ventilator and a cough assist machine. If you have a max inspiratory pressure less than 60, you might qualify for a home vent. A max expiratory pressure less than 60, you might qualify for a cough assist, or a peak cough less than 270, you might qualify for a cough assist. I tend to use spirometry, MIP, and MEP in my clinic personally. That's what we're just used to doing. I do peak cough occasionally, but for the most part, I can get the proper equipment for patients with those three.
I have a question for you real quick, doctor. When you talk
Please.
about home vent, are you talking about like CPAP and BiPAP?
Yeah, that's a great question. And you've beat me to my next slide.
Okay, sorry.
Yeah, no, you're fine. And please, if anybody has questions, absolutely interrupt. So the three pieces in patients who were really concerned about their lungs for, the things that we try to use to give you tools to be able to stay home when you're sick, not be hospitalized, get through illnesses better and cough better and breathe better. One is a pulse ox. Having a medical grade pulse ox is really important. So being able to accurately measure oxygen levels is really important during illnesses. Thankfully, in Iowa, I have not had issues getting this for patients through insurance if they don't have home oxygen. For the few patients that I see in Illinois, that can be an issue. So this may be a state-to-state kind of thing of getting a pulse ox if you don't have oxygen at home. A home ventilator would be something that has the ability to do CPAP or 2 levels BiPAP, but it also has other features to it where you can say, pick a target volume and the vent tries to meet that lung volume with every single breath, which really helps with lung expansion. So the way I try to explain it to my residents or my students is, imagine going through life and you can never really take a good sigh breath. You can never go, ah, and you do it and it feels good and you can relax your chest. But if you can't do that, what are some tools we can give you so that you can take at least bigger breaths and get nice breaths when you're sleeping? When you're laying down, your diaphragm isn't working as efficiently because gravity isn't helping it move down, and your accessory muscles, because you're in REM sleep, turn off. And so a home vent is a great tool for that. That can either be through a nasal mask or a full face mask, or in some cases through a tracheostomy tube. And then the last piece of respiratory equipment we look at and try to get is, and I probably should have reordered this because it comes before the home ventilator most of the time, is the cough assist device. So it's about the size of a laptop. It has most of the time they have a touch screen. The old devices are kind of getting phased out of the US market, and these are the newer devices that are going to become more prevalent and prominent. So it has this screen. It attaches tubing to a face mask. And what it does is it helps you take a big breath in, and then you start coughing, and it pulls a negative force out to amplify your cough or help you get mucus out of your lungs. So it's a really important piece of equipment and super effective for our neuromuscular patients. Home ventilators can be different shapes and sizes. Usually they're about the same size as a cough assist device. And again, they connect with tubing to some type of face mask interface, whether that's the nose or the nose and mouth. And each of these have their own kind of nuance of settings. But for the most part, the way that I was trained in my fellowship, and I think the way that a lot of people treat sleep-related issues is trying to target a volume. So getting a nice, big, good-sized breath that's still comfortable so that kids can take good-sized breaths throughout the course of the night and sleep more efficiently, sleep better. I think matching the vent settings with a sleep study can be helpful. I'm not as interested in that in my neuromuscular patients. I'm more interested in, is this comfortable for you? Does this help you sleep? Can you wear it? And do you feel good when you wake up? And those are the things that are more important to me. So the goals of treating your lungs in FSHD: preserving lung function. So identifying aspiration and addressing it. Identifying who needs a cough assist device and helping them get mucus out of their lungs. Preventing pneumonia, keeping you home when you get sick. Preserving your lungs and keeping them clean is essentially how I try to explain that. Enhancing survival. So in the appropriate patients, non-invasive ventilation has been shown to increase survival and quality of life measures across neuromuscular diseases. It's not right for everybody. I've tried a home vent. I've tried one on like just BiPAP. on low settings, it's incredibly uncomfortable. But if you need it and it feels good, then you are going to benefit from it. And then staying home when you get sick. I love seeing my patients. I don't love seeing them in the hospital. I love seeing them in clinic. And so what are tools we can give you to stay home? So whether that's a non-invasive home ventilator to help improve CO2 clearance or oxygenation when you're sick, so you can stay home longer and safer, and a cough assist device to help prevent pneumonia, and a pulse ox for helping you monitor all of those things. So my sick plans for patients who qualify for, say, a cough assist and a home vent would look something like, it's all mirrored off of Duchenne literatures where we steal a lot of stuff from. But in the setting of an illness, do your cough assist twice a day at least. If you need it more than that, that's fine. If your oxygen levels are less than 95% and they are normally above that, they're normally 98, 99, 100, you should do your cough assist every 4 hours, because that indicates to me that you have mucus in your lungs and we need to get it out of there. And if your oxygen levels are less than 90%, then you need to go on your home ventilator, continue your cough assist, and seek care in the emergency department. And then we have a protocol with calling into the clinic. We can help with chest x-ray and labs and different, early antibiotics, that kind of stuff at that point versus admission. So back to our case. So for our patient who had this kind of classic expiratory pattern, kind of boxy shape to their expiratory curves, their FVC was 74, so didn't quite meet criteria for a home vent. It was a little too high. They did a max inspiratory pressure of 79, which is also above 60, so it doesn't meet criteria for a home vent. FEV1 is greater than 60, so doesn't meet any, or this is also greater than 60, so doesn't meet criteria for a cough assist device. And our patient wasn't able to coordinate for a MEP or a max expiratory pressure. I think it would be pretty close to normal. So we weren't able to get this patient any equipment, but that's okay. We were able to get a swallow study and get a sleep study for them to make sure that those things were okay, because that's the stage that they were at that time. And so just kind of taking everything stepwise and saying, what are the things we can help you with now, and preparing for what things we might be able to help you with down the road are the goals for clinic visits for me. So I tend to talk too fast, so I apologize if I did, but what questions can I try to answer?
Thank you, doctor. I have a couple of questions. What kind of precautions do you need if you're going under anesthesia, if you're getting like surgeries? I know before my son had surgeries, he had to go to the pulmonologist and do some things, but maybe if it's an emergency situation, like what sort of things do we need to be aware of in that case with respiratory?
So if you have a home ventilator, then take it with you to the procedure. If your child is being intubated, we always tell our anesthesiologists, unless they're going to extubate to room air, you should extubate them to their home BiPAP or their home vent, so that they're on settings that we know that they tolerate, that we know that do well for their lungs, and we avoid having situations where maybe not everybody realizes how weak some patients are, and instead of making sure that they're not retaining CO2, they just increase oxygen up, up, and up, and then you get into serious problems. I think every center has heard stories of things like that happening in the past, and so we're all very cautious. So my advice is always, unless it's like very, very low amounts of oxygen, try not to do any oxygen by itself ever without also having a vent, if that patient has a vent at home or will qualify for one. For patients who are maybe not at that stage of their disease yet, I think it's not as big of a deal, but also they shouldn't need that much oxygen coming out of anesthesia anyways. So it still is something to be cognizant of, that if oxygen levels are continuing to go up, have someone check a blood gas and make sure CO2 is not too high. They don't need more support.
So would they coordinate with the pulmonologist that's seeing the patient? So say if my son's going in for a surgery, that surgeon should coordinate directly with you to make sure that all those things are taken care of, correct?
Yeah, and anesthesia would be the two groups that all need to be on the same page. So us, surgery, and anesthesia all need to have some understanding of this. So For my neuromuscular patients who get spinal fusion or have scoliosis repairs, scoliosis surgeries, all of us are very used to taking care of that particular issue. And so there's a really nice protocol and culture for safety for those patients. I think it's, if you're even having minor things that maybe the surgeons aren't as used to it, so dental procedures that's at the home office, other things that are maybe out in the community for patients who are pretty weak, I do worry about that. And I like when it's done at a major medical center so that you have trained pediatric anesthesia who are on top of these kinds of things and can recognize them.
What about emergencies? Like I got my son a medical alert bracelet that just says, no oxygen or anesthesia, just
Mhm.
it's alert. And I know the FSHD Society has this card you can fill out that's just centered around anesthesia and respiratory function. Would you recommend something like that, like carrying that?
That's a fantastic idea. Yeah, because I do think that even in at major medical centers sometimes, I think that, say you need to go to the emergency department, not everyone is going to be as familiar as you are with the care that your kid needs. And you can be the best advocate you can be is someone who doesn't let, that situation of oxygen just going up and up and up without having the ability to have your kid also take big breaths along with it to clear CO2 out. Yeah.
And
So yes, I agree with you. Cards are great, but being able to also advocate for them is a really important part. And so I do think parental advocacy before procedures and in emergency settings is super important and oftentimes even more effective than what we say and do.
okay, what about pectus excavatum? Does that impact the lungs? There was a parent who wanted me to ask specifically about that.
Yeah, it's a really good question. It's sometimes very hard to tell. Uh, there, it can impact. So if the pectus is big enough, if it's deep enough, it can compress the airway or compress part of the blood vessels, and it can change, especially what we see as activity intolerance. So in people who don't have neuromuscular weakness, we can see some amount of exercise intolerance. If you have neuromuscular weakness, I think it becomes much harder to tell what's causing what. And so then the question is the surgery, are you going to get the benefit from any potential surgery, and risk benefit, is that worth it? And I think that just takes having a few people who are familiar with all of those issues, kind of talking about it together to come up with a plan together. It's a great question. It's a really hard one to answer.
The other question I had, my son, he's 19 years old now, and we've been doing this for, gosh, 16 years, I think now. But when he goes in and gets like his lung function test, it's always a struggle because of the facial weakness to get a
Yeah.
good seal and all this. And
Yep.
what is, I think finally, after a lot of years of trial and error, they finally got a mask that goes all the way over, and they kind of just really put a lot of pressure on him. What is the training like? Is everyone trained to do that? Are the lung function tests reliable because of the facial weakness? And also, how often should you go and see your pulmonologist and get those tests ran?
Yeah, all great questions. In terms of training, I don't have a good answer. For us, we have really great respiratory therapists who do have experience with pediatric neuromuscular disease. So I think our results are pretty accurate, but it's correct that because of the facial weakness, it can be really hard to get a good seal. And so that can change your results. One way to look at that is maybe that gives you an opportunity to get some equipment a little sooner because it kind of disproportionately says things are a little worse than they really are. Now, that doesn't mean that I think that everyone should have a home vent, even if they don't really need one. But I do think it gives you an opportunity for a cough assist device sometimes. And that's a tool that I think is much easier to use just as needed. If you're sick, as long as you know how to use it, and you can get benefit from it when you need it, that is something I'll kind of maybe just take the value for what it is and report that to try to get the equipment. In terms of how frequently, I think that's patient dependent in some ways. I think for some of our other neuromuscular diseases, we say once you're non-ambulatory or can't walk, we see you at least every 6 months, and we try to do lung function testing every 6 months if you're able to. For FSHD, I think it depends on the patient. If they're still mobile, it depends on what what kind of all of the collection of issues are. But I do have patients with FSHD that I do see every 6 months, just to make sure that we're not missing anything related to sleep and aspiration, mainly. Because overall, they're otherwise functioning, pretty well, given the circumstances.
Allie, can I just go back to the question about emergencies? I was just wondering if you could recommend exactly what you would put on a bracelet, because I'm just concerned if you put FSHD, will they know that the concern is about respiratory function? Do you rate CO retention? And what would you
Yeah, that's a
advise
really good.
to
It's a really
warn?
good
Because I
question.
don't know if they'll think about respiratory if we're warning people about muscular dystrophy.
Yeah, no, it's a really good question. I don't have a great answer. Let me talk to our neuromuscular team, and I'll try to send an answer back out through Allie. I think talking to Dr. Matthews and the kind of see what they recommend on those things, because I'm usually not involved in putting stuff on those bracelets.
So I have another question as well. So my son has had a cough assist machine for years, and we've used it when he's sick, but his pulmonologist recommended, because he's had such a hard time with the BiPAP, like he has one, but it's real uncomfortable for him. We've had a hard time getting the settings right because of the facial weakness, and his cheeks just kind of blow out, and he doesn't get good sleep. What she recommended and was that he used the cough assist sort of backwards, like he puts the face mask on and just blows up his lungs and inflates them, every morning and every night, just to keep, what she said was to keep his lungs like elastic and to keep them open all the way down, because she said they can get sticky on the bottom if they're not inflating all the way. And so she recommended, until we can get the BiPAP set correctly, just use that cough assist and just inflate and take a deep breath as you can, at least twice.
Yeah, you can also breath stack, so you can do a big inhale and then do another inhale until you get to kind of a big volume, as a way of trying to get expanded and prevent atelectasis or lung from getting sticky and collapsing. I don't know that there's any data about, like, in the literature about doing that, but I do think functionally that it probably makes kids feel better, because again, you're just achieving that goal of every once in a while getting them to take a nice big breath. So I think if there are periods when any kid feels short of breath, that's always a reasonable option. Not using cough assist to cough, but using it to try to just do the inhales to take big breaths. We call it hyperinflation. And so when you're doing cough assist, you do kind of 4 or 5 cycles of these inhale, exhale cycles. And we always say to end on an inhale, so that you end with your lungs nice and inflated and not at the low point where it's hard to then take a breath to get them open back up.
So, doctor, we have unfortunately had a couple of kids pass away because of respiratory issues with FSHD, and I don't know all the details, but I think it's just they couldn't clear their lungs, and they did have a cough assist, and I think their parent did try to help them clear their lungs. But at what point, because it gets scary really quickly, like I've been in this situation. My son has had to gone to the hospital because of just too much junk in his lungs, and I don't have a medical grade pulse ox. I just have an over the counter one, but when it gets low, you gotta take them. At what point do you just, like, it can't clear, that it becomes an emergency, that you just need to go? Is it just if it's under 90, or if it's just they feel like they're struggling?
No, yeah, I think when you're getting into that kind of subjective stuff, I trust you guys. So if you know your kids better than I do. So if you're not comfortable with what you're seeing and you think you need to go to the emergency department, just do it.
And they can
I
suck
think
out the mucus in a different way, is that right?
sometimes there are suction devices, or if kids, the other piece of medical equipment we can sometimes get for kind of kids who have facial weakness or a hard time controlling secretions would be a suction device. But like doing deep suctioning, or I think the question would be, are they at risk of needing a breathing tube at that point? And I think you just need to go to the emergency department. In those types of situations, if you don't have any more tools to help and you're really uncomfortable with what's going on, just seek care.
Okay. Christina, you have a question?
Yeah, Allie, thanks for organizing these. It's so nice that you do this. And thanks, Dr. Hinds, for doing this. I have an 11-year-old named Alexa who has FSHD, and it's her lung issues that are the most kind of painful part of her diagnosis. And we have all the things that you mentioned. She's on kind of even prophylactic antibiotics all the time, and she's healthy. And so that's awesome. It all seems to be working. And I also just want to echo Allie, I've so been in those positions of like, God, it gets scary really fast and what to do. And it's really, you're right, doctor, that it's subjective, but oh my God, it's a lot to carry. But my question that you sparked for me that I haven't really thought about in our whole journey on this is the CO2 piece. So we actually also, in addition to the things you mentioned, we have home oxygen, which it's like prescribed on an as needed basis. We've got both a tank and a, is it called a compressor that makes it with room air?
Yep.
And so we pull that out in the luckily rare case when she's really struggling, and we use not a professional grade oximeter, but just the Amazon kinds, and we can see her struggling. I have never thought about needing to worry about CO2 while we're kind of amping up, and we're not amping up out of control. We're going up to, pretty low levels of oxygen, but do you have tips? Like, I guess a couple questions. Are there like things we can use at home to monitor CO2 levels, or are there tips for ways?
In general, no, there's nothing that really is available for measuring CO2 at home. At least not that I'm aware of. Capnometry is the way we do it in the hospital, and it's in general not available commercially or outpatient. My rule of thumb, and maybe this is just me, but my rule of thumb is I generally don't give oxygen to patients with neuromuscular diseases unless they're on their BiPAP and you're bleeding it in through BiPAP, because that at least guarantees to me that you're taking big enough breaths to clear your CO2. And maybe we can use your oxygen to make you feel more comfortable and keep you at home a little longer, but in a safe way. Because I just think, I don't think, I worry about if we use oxygen by itself, that when you end up needing to come in, you're going to be sicker and in a worse spot. And you actually came in to, like, are you going to end up coming in too late is what it concerns me about. That doesn't make that philosophy right, but that's in general, just at this, stage of caring for neuromuscular diseases, that's what I'm comfortable with doing, is I generally don't do oxygen without doing it with a home vent or BiPAP.
Yeah. And are there signs clinically or physically that there's a
altered mental
problem?
status? Like if your kid is just not acting like themselves, if they're really not mentating well, if they're just very depressed and not depressed like in a mood way, like they're not interacting normally, they're not thinking clearly, that kind of fog feeling, that can be a sign of CO2 elevation.
It's
Other
tricky
than
because
that,
those
there
are
aren't
the
a ton of them.
same, that's how I would describe when she needs oxygen,
Yeah, yes, totally. So it's all very non-specific, and that's why it concerns me, is because there isn't a good way to monitor it. So at least doing it through BiPAP makes me feel better that so that one thing that can happen is if your CO2 is pretty high, that can cause your oxygen levels to be low. There's only so much gas you can fit in your alveoli. And I can't tell the difference between that and you having a lot of mucus in your lungs, and that's why your oxygen levels are low. So to me, if your oxygen levels are below 90, you just need to be on your non-invasive. And then if you have oxygen, you can bleed that in through it.
Yeah. Okay. That's hard because BiPAPs are super uncomfortable, but it's good information.
Yep. Yep. And like I said, it's not, if you have a plan with your physician that you are both comfortable with, then I would completely defer to, whatever you guys are already doing. It doesn't make either one of us right or wrong. That's just what I recommend.
Yeah, no, that's great. Thank you.
Thanks. Gary, do you have a question or Arlene?
I actually have a question. First of all, Ali, I agree with you. So if with the doctor that if your son is symptomatic and you're uncomfortable, you just go to the emergency room. There's nothing to hold you back. But I did have a question about hyperventilation you had talked about. My son can't wear that BiPAP machine either. But can you do hyperventilation on a BiPAP, or do you have to have the cough assist?
You can breath stack on a BiPAP. I think it's just easier with a cough assist. The way that, because you can program a specific setting so that it gives you just an inspiratory pressure for a set amount of time. And so you can have a setting on it where you're just trying to get a nice big breath. So I guess theoretically you could do it on a BiPAP. I just probably wouldn't. I think it's easier to do it with cough assist.
You said, how did you qualify again for the cough assist machine? Was it high CO2?
Yeah. No, it's if your max expiratory pressure is less than 60 as a raw value,
Okay.
or if your FVC on your spirometry, your loop breathing test, if that's less than 50th percent, it might be 60th percent. I'll have to look and double check that, but it's definitely at 50%. You qualify for both a vent and a cough assist.
You said SVC?
FVC, yep, of less than 50, and a max expiratory pressure less than 60.
Okay.
Doctor, I have one of the really old cough assists, like the big ones. Do you think that I should, it works fine, but should I upgrade to one of the smaller ones, or if it's working as
I would. So does your machine have oscillations in it? And can you have multiple settings in it?
No, it's got like it's old. It's got like all
Yeah.
the dials and then just like the needle.
I would. So I think the newer machines, there's a couple of benefits. One is you can have many different settings. So if you want to experiment with different things, you can do that. And you can see what's comfortable and what's effective and what the balance is of those two things. The other thing is that the newer machines have a pressure during the pause. So when you go from the breath out to another breath in, it gives you a little bit of peep. So you can help to get lung volume back when you go to take another breath in. So they're a little bit more comfortable. And then the third thing is that the machine can cause the tubing to shake and provide some oscillations. So it helps to break up mucus in your trachea and cough it out easier. It doesn't, if anyone's ever heard of like IPV or a metaneb, it's not that type of oscillation. It's mainly just for tracheal secretion. And some kids who get nauseous don't like it. But if you can tolerate it, then it can be a really effective way of even enhancing what you're already doing with the cough assist device.
So the other question I have is about albuterol, right? So my physician prescribed a nebulizer to me a long time ago. And when my son starts getting junky, I get him on it right away. Like, because I've learned over the years, if you wait, then it gets worse. And then that's when he ends up with pneumonia and we're in the hospital or whatever.
Yeah.
Would you recommend that families, if their child is prone to mucus settling into the lungs, to have a nebulizer and albuterol on hand? And he prescribed something else to me. It's like a steroid with albuterol solution as well.
Budesonide?
Yeah, I don't remember the name of it. What are your thoughts on that, on the nebulizer?
I think it depends. That's a patient-to-patient thing. So, yes, you can have, so the thing that albuterol particularly helps with is if you also have asthma. If you have, so asthma is a particular lung disease where your smooth muscles clamp down and you have lung inflammation, and it makes it hard to get air out of your lungs, and you wheeze and you cough. The albuterol helps to relax smooth muscles in your airways to make it easier for you to breathe. So if you have that particular lung disease, then yes, albuterol is a great tool. Theoretically, albuterol may improve how you have little hairs that line your lungs. They're called cilia. And it may increase the frequency that they beat to improve airway clearance. Whether it actually does, I've never been convinced of that. I do think that it provides some moisture and hydration for secretions and helps move them. So part of me wonders if we just did like normal saline nebs, or if we did good nasal hydration with like normal saline spray, if that would have the exact same impact that albuterol does. I don't think it's harmful unless your kids get, you know, jittery or tachycardic with using it. I don't think it's the wrong thing to try at all. And if they have asthma, then we should definitely treat it. But I don't recommend it for everybody across the board. I think in the right situations, it's great. I think that sometimes it can be effective or helpful if you don't have asthma, but maybe there are other ways we can accomplish that as well, like just providing hydration and moisture.
Does having a humidifier in the room at night help?
Some pulmonologists have love-hate relationships with humidifiers because if you don't clean them, then basically you're just aerosolizing junk that grows in it. So I tend to not recommend them. I personally don't find them very effective. If you live in a really dry climate and you just want to try it, there's nothing wrong with that. Just make sure that you're cleaning it well and you're not letting, you know, stuff grow in it, and that you're also not nebulizing things that have a lot of scent or like essential oils or other stuff like that, because I think those things can increase lung inflammation and make things worse, not better.
Yeah, our son actually uses it more because he can't close his eyes for moisturizing.
Yeah. So I think that's totally fine. I would just make sure that it's being cleaned out regularly per whatever the manufacturer recommends.
I know, I think that's a good point because you tend to forget about cleaning it, just filling it up. That's good. What happened?
Okay.
I was going to offer just real quick, if any of you are doing albuterol, we have switched to lev albuterol as one way they call it. What we find is it doesn't make her hyper. And sometimes with albuterol, you know, you'll administer it, especially at night, and it gets in the way of sleeping. But the lev albuterol doesn't have that side effect. So anyway, just a tip.
Lev?
LEV.
Zopanex is the other name
Zopanex,
for it.
right.
It's basically just half-strength albuterol.
Okay.
Yeah, way back when albuterol was tried as a treatment for FSH.
Like systemically?
Yeah, orally.
Yeah. Yep.
Didn't work.
No, it didn't work.
Doctor, and this is just a purely opinionated question. What do you think about diaphragmatic sonograms as like an outcome or an endpoint for treatments for FSHD? I know there's a study going on in France right now.
Yeah, I probably don't know enough to actually have a good opinion. I am aware that, like, I think that we are looking at diaphragms more in the context of neuromuscular disease and in other lung diseases that, like, you know, intubation in the PICU, and how can we improve how we care for diaphragms as a way of getting breathing tubes out. So I do think that we're looking at it more across multiple different diseases. I don't really know enough about what to do with those types of values to have a good opinion on it. Sorry, I'm not a great person to ask that one up.
That's okay. So you said you didn't have a lot of FSHD patients?
I don't have a big number, just a handful.
Of the ones that you have, do most of them have some sort of respiratory, I don't know, some issue, I guess?
I would say not yet. I would say not yet. They do have some issues, but not a ton of home vent use, or maybe a little bit of more cough assist use than home vent. But no, not yet.
Okay.
Luckily.
Right.
I have a
Yeah.
question.
Yeah. Okay.
Yeah,
So
please.
just to clarify, doctor, you suggest to use the cough assist for to hyperventilate to help the lungs, even if they're not sick, to use it as like preventative?
Yeah, I think you can do that, or you could, depending on just, patient to patient, I think the other way would be if they feel short of breath, then you could use it to try to get them a nice big breath and get them that sigh breath that we were talking about.
Okay. Are there other exercises that she can do, just as part of her routine, when she's doing her physical therapy? Are there exercises that she can do that doesn't require like a machine?
That's a great question. Not that I'm aware of that would it particularly help with like lung recruitment. But have you ever asked your physical therapist that?
No, actually, she doesn't qualify for the cough assist,
Okay.
but I want to push now to try to get one.
Yeah, sure.
Knowing that it could be preventative.
Mm-hmm. Yeah, I would ask, some other members of your care team if they're aware of any exercises. There's nothing that comes to mind on my end, but I think that's a great question.
Okay. Thank you.
Can I ask another question about equipment?
Sure.
Our daughter uses I call it a vest machine. I can't remember the proper name for it.
Yep.
It's really huge. And so
Mm-hmm.
anytime we go anywhere, it's a lot to manage.
Yeah.
Are you aware of any changes in that technology with anything smaller on the market?
I'm sure that there are, those vests are definitely shrinking. I think the caution for me is the weight of it. Is it so heavy that it makes it harder for your kids to take a good breath? I think that the shaking is great, but if you can't cough your mucus out, then it's kind of pointless. So I would always recommend finishing with cough assist after you do it. And I tend to not get them for my patients as much. I'm more of a, let's just do cough assist and try to simplify your life and not use things that are going to put a bunch of weight on your chest. But I do think that they can be helpful, and I do have some patients who have them, as long as they're doing the cough assist after.
Okay, that's good to hear. Thank you.
Are there any other questions?
Iowa,
Where is it?
Iowa.
No.
No other questions, Gary? No?
No, we're good.
Okay. Well, we're about out of time. I appreciate you so much, Dr. Hinds. This is very, very, very valuable information, and this is recorded and this will go out, and if we get questions, then I will email them to you, and hopefully you can help us out with those. I appreciate you being our guest. Do you have any last minute words for us, or anybody else have any last minute questions for Dr. Hinds?
I do. Do you want to move closer to New York City?
I'm good for now, but I'll keep you posted.
Okay, thanks.
Thank you guys. I really appreciate the invite. It was a lot of fun for me. So thank you for the opportunity.
Thanks for joining us. It was very informative. You have a great evening, and thank you so much.
Thank you.
Take care.
Thank you.
Thanks, everyone.